Hello friends, welcome to my YouTube channel T&C Updates, Toxicology and Critical Care. Before starting today's video, there is a disclaimer. The following videos touch various important topics of critical care medicine and toxicology. The videos are not exhaustive account of the disease conditions discussed. The videos derive their content from various standard textbooks of medicine, critical care, toxicology. But as the guidelines change rapidly as per the new level of evidence, the viewers are strictly advised to follow the discretion and advice of the training specialist. Today's video we will learn about a very important organ of human body, the renal system. 50% of ICU admissions suffer from different grades of renal insults. Before starting today's video, let us try to answer the following question. Following urinary findings are suggestive of pre-renal disease except number 1, specific gravity is high, that is more than 1.018. Spot urinary sodium is low, less than 20 millimoles per liter. Osmolality is more than 350 milliosmoles per liter, or fractional excretion of sodium is more than 1%. Second question, all of the following are true with regard to nutritional management of critically ill patients with AKI, acute kidney injury, except target plasma glucose of 110 to 149 mg/% with insulin therapy, target energy intake of 20 to 30 kilocalories per kg per day with any stage of AKI. Protein intake should be restricted with the aim of delaying initiation of renal replacement therapy. Administer 1 to 1.5 grams per kg per day of protein to patients with acute kidney injury on renal replacement therapy. So let us see if we are able to answer these questions very easily after going through the presentation. How do I approach a patient of acute kidney injury? Initially, it is important to know whether it is acute kidney injury or acute kidney injury occurring on the background of chronic kidney disease. Application of Kidney Disease Improving Global Outcomes Guidelines helps us to stratify acute kidney injury into various stages and grades. How do I define acute kidney injury? Acute kidney injury is defined by any of the following. Increase in serum creatinine by more than 0.3 mg/% within 48 hours, or increase in serum creatinine to 1.5 times, that is more than 50% times the baseline value within the prior 7 days, or number 3 is oliguria, that is urine volume less than 0.5 ml per kg per hour for 6 hours, at least 6 hours. So acute kidney injury network classification of acute kidney injury, that is gradations. 3 grades: increase in serum creatinine more than 0.3 or increase in serum creatinine 1.5 to 2 times, or the urinary output criteria less than 0.5 ml per kg per hour, say for 6 to 12 hours. Grade 2, serum creatinine is 2 to 3 times the baseline value, or urine output 0.5 ml per kg per hour, less than that for 12 to 24 hours, say. Grade 3, serum creatinine more than 3 times, or if baseline serum creatinine is more than 4 mg/%, then increase of serum creatinine more than equal to 0.5 mg/%. Urinary output, if it is less than even 0.3 milliliters per kg per hour for 24 hours, or anuria for 12 hours or more. So this is traditional classification: pre-renal, renal and post-renal. In ICU settings, Sepsis is the most common etiology, causing acute kidney injury by renal hypoperfusion, microcirculatory disturbances, tubular changes, and renal inflammation. So differences between pre-renal and intrinsic AKI. So pre-renal, you will have urea to creatinine, urea nitrogen to creatinine more than 20, filtered sodium less than 1, here less than 20 and more than even 2%. Filtered urea less than 35, more than 35. Urine osmolality in pre-renal more than 500 milliosmoles per liter, less than 400 milliosmoles per liter. Urinary sediment type, that is microscopic examination, bland haline casts, whereas in renal diseases you will have granular casts. Urinary sodium in pre-renal causes you will have less than 20 milliequivalents per liter, and in renal causes you will have more than 40 milliequivalents. Important thing is that in this classification doesn't hold good if the patient is on diuretics. If the cause is pre-renal and you put the patient on diuretics, then urinary sodium will be falsely more. So these are the investigations we generally go for. If it is glomerulonephritis, vasculitis, we go for various tests like antinuclear cytoplasmic antigens, ANA, antiglomerular basement membrane antibodies. So this diagnosis is of exclusion when we have excluded all other causes. Interstitial nephritis will present with eosinophilia, eosinophiliuria, renal biopsies can be done. Interstitial nephritis can be caused by various drugs also, like even pantoprazole can cause interstitial nephritis. Then various coagulopathies can be cause of a renal disease, like thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Here we will go for PBFs and various blood tests. Then other causes like abdominal compartment syndrome can cause various renal malfunctions. So we will measure the pressures, intra-abdominal pressures, intravesical pressures that can be measured. Then various trauma patients can present with various malfunctions of the renal system. Rhabdomyolysis, we will go for CPK, urine myoglobulins. Then various tumors, blood cancers, myelomas, where we will go for serum electrophoresis, renal biopsies. Then the most common cause, sepsis, sepsis screening, cultures, blood and urine cultures. Then cardiorenal syndromes, 2D echo, anti-pro-BNP and troponins. Then causes of AKI, susceptibilities and exposures. Exposures, sepsis, critical illness, circulatory shock, burns, trauma, cardiac surgeries, major non-cardiac surgeries, various nephrotoxic drugs. Then radio contrast agents, a very common cause these days because we are more dependent on various radiographic measures. So various IV contrast agents are given. So this is very important these days. Poisonous plants and animals. Then susceptibilities, dehydration and volume depletion. Advanced age, female gender are more susceptible. Black race, if already CKD is there. Chronic diseases, heart, lung, liver, diabetes, cancer, anemia. So these all predispose to the AKI. More than 30% of patients who recover from acute kidney injury remain at increased risk of chronic kidney disease, cardiovascular disease, and death. This calls for identification of risk factors that can identify such patients in the hope of providing them with timely preventive measures. Evaluation and general management. Evaluate patients with AKI promptly to determine the cause, with special attention to the reversible causes. Monitor patients with AKI with measurements of serum creatinine, urine output to stay the severity according to the recommendation. Manage patients with AKI according to stage and cause. Evaluate patients 3 months after AKI for resolution, new onset, or worsening of pre-existing CKD. So we have to classify the patient whether it is AKI, acute kidney injury, acute kidney disease, and chronic kidney disease. So acute kidney injury, as we have already discussed, I will not repeat, but important thing to note is that in acute kidney injury, there is no structural criteria because the ultrasound will be normal, CT will be normal, so there are no morphological changes as such. But when we go for CKD and AKD, there will be structural criteria. We will see some damage in the USG and other radiological investigations. In CKD, the damage is for more than 3 months, whereas in AKD, the damage is for less than 3 months. Then another criteria that is taken into consideration is glomerular filtration rate. So GFR is less than 60 ml per minute per 1.73 square meter for more than 3 months. That is chronic kidney disease. What is acute kidney disease? Acute kidney disease is acute kidney injury for less than 3 months with kidney damage on the radiological investigations. So any AKI which has a radiological investigation positive for kidney damage positive and which is less than 3 months is acute kidney disease. Or it can also be independent of acute kidney injury. That is, AKD can also exist in isolation, that is without acute kidney injury. GFR is less than 60 ml per minute per 1.73 square meters for less than 3 months, or decrease in GFR more than 35%, or increase in serum creatinine by more than 50% for less than 3 months. So that is also acute kidney disease. And no known kidney disease, GFR is normal and there is radiologically no positive investigation. So these are examples. We have a GFR more than 60, and if GFR is more and we have an increase of creatinine and next 3 months it's not applicable, that is AKI. GFR is okay if the creatinine is less then 1.5 increase, and GFR during the next 3 months is less, that it goes below 60. So we have acute kidney disease without acute kidney injury. And if the baseline GFR is again more than 60 and serum creatinine less than 1.5 increase and GFR during next 3 months is more than 60, then it is all normal. Similarly, if baseline GFR is on the lower side, and if baseline GFR is on the lower side, then we will always have a CKD plus or minus any of the things. So if GFR is less than 60 and creatinine is more than 1.5 during the next 7 days, then we see the radiological, then it is AKI plus CKD. If GFR is less and change in serum creatinine is less than 1.5 times plus GFR also decreases further more than 35% during the next 3 months, then it is CKD plus AKD. If GFR baseline is less and change in serum creatinine is less than 1.5 times and GFR during the next 3 months is less than 35% decrease, then it is the continuing CKD which is already there. So why we have to take so many criteria? Why not oliguria alone as a measure of kidney function? Because oliguria alone can be it can't reflect the whole function. If GFR is normal, approximately 125 ml per minute, corresponding to 107 ml per kg per hour for a 70 kg adult, then reduction in urine volume to less than 0.5 ml per kg per hour would reflect reabsorption of more than 99% of GFR. Such profound stimulation of tubular reabsorption usually accompanies circulatory disturbances associated with decreased GFR. In principle, oliguria as defined by the definition of AKI can occur without a decrease in GFR. For example, low intake of fluids and solutes. Urinary concentrations of sodium, creatinine, fractional reabsorption of sodium and urea remain helpful to distinguish among causes of AKI but are not used in the definition. So, what is a normal thing? What is happening in the 24-hour picture? Substances which are filtered and reabsorbed. If we see what is a normal urine output, 1 to 1.5 liters in a normal adult. So actually 180 liters is the filtered and 179 liters almost can be reabsorbed and only 1 liter comes out as urine. So this 170 plus liters is reabsorbed. So this fraction is adjustable as per the antidiuretic hormone on the collecting tubules. So in less fluid intake, although the GFR will be normal, but the urine output can be less. So oliguria can't be taken alone. Proteins in normal kidneys, there is no protein in the microscopic examination. Chlorine 5 grams comes in the urine, rest is reabsorbed. Sodium 540 is the amount filtered, 537 is reabsorbed, and 3 grams comes out in urine. Bicarb minimal 0.3. Glucose normal urine contains no glucose. Urea 25 grams. Potassium 4 grams. Uric acid 0.8. Creatinine nothing is reabsorbed. Everything comes out in the examination. Prevention and management of acute kidney injury. In the absence of hemorrhagic shock, guidelines recommend isotonic crystalloids rather than colloids as initial management for expansion of intravascular volume in patients at risk of AKI or with AKI. The use of vasopressors is recommended in conjunction with fluids in patients with vasomotor shock with or at risk for AKI. Protocol-based management of hemodynamic and oxygenation parameters to prevent development or worsening of acute kidney injury in high-risk patients. What are the goals? Number 1, return of mean arterial pressure to more than 65 millimeters of mercury. Number 2, improvement of blood lactate levels to less than 2. And number 3, we can have central venous oxygen saturation more than 70%, CVP around 8 to 12 millimeters, urine output more than 0.5 ml per kg per hour. So all the parameters are used in conjunction. No parameter alone is sufficient. So glucose control, nutritional support. In critically ill patients, guidelines suggest insulin therapy targeting plasma glucose 110 to 140. A total energy intake 20 to 30 kilocalories per kg per day is recommended in patients with any stage of acute kidney injury. Avoid restriction of protein intake with the aim of preventing or delaying initiation of renal replacement therapy. A protein intake of 0.8 to 1 gram per kg per day in non-catabolic acute kidney injury patient without the need for dialysis and 1 to 1.5 gram per kg per day in patients with acute kidney injury on renal replacement therapy and up to a maximum of even 1.7 gram per kg per day in patients on CRRT and in hypercatecholic patients is recommended. Nutrition preferentially by the enteral route. The guidelines recommend not using diuretics to prevent AKI and not using diuretics to treat AKI, except in management of volume overload. Dopamine guidelines recommend not using low dose dopamine to prevent or treat acute kidney injury. Guidelines recommend not using phenoldiazepam to prevent or treat acute kidney injury. Similarly, guidelines are against the use of atrial natriuretic peptide and recombinant human insulin growth factors. Prevention of aminoglycoside and amphotericin-related acute kidney injury. Guidelines suggest not using aminoglycosides for the treatment of infections unless no suitable, less nephrotoxic therapeutic alternatives are available. In patients with normal kidney function in steady state, aminoglycosides are administered as a single dose daily rather than multiple dose daily regimen. Guidelines recommend monitoring aminoglycoside drug levels when treatment with multiple daily dosing for more than 24 hours. Guidelines recommend monitoring aminoglycoside drug levels when treatment with single daily dosing is used for more than 48 hours. Use topical or local applications of aminoglycosides rather than IV when feasible. Guidelines suggest using lipid formulations of amphotericin B rather than conventional formulations. In the treatment of systemic mycosis or parasitic infections, use azole antifungal agents or the echinocandins rather than conventional amphotericin B if equal therapeutic efficacy can be assumed. Contrast-induced AKI. In individuals who develop changes in kidney function after administration of IV contrast media, evaluate for contrast-induced AKI as well as other possible causes of AKI. When possible, administration of contrast media should be delayed in patients with circulatory collapse or CHF until their hemodynamic status is corrected. Repeated exposure should be delayed for 48 hours in patients without risk factors for contrast-induced AKI and for 72 hours in those with diabetes mellitus or pre-existing chronic renal dysfunction. In acute renal dysfunction, if acute renal dysfunction develops after contrast, then repeated exposure should be delayed until serum creatinine has returned to the baseline values. Concurrent nephrotoxic medications, NSAIDs, aminoglycosides, amphotericin, loop diuretics, acyclovir should be preferably be stopped before angiography. Pharmacological prevention strategies. Guidelines recommend IV volume expansion with either isotonic sodium chloride or sodium bicarbonate solutions rather than no volume expansion in patients at increased risk for contrast-induced AKI. Most studies suggest that the fluid should be started 1 hour before and continued for 3 to 6 hours after contrast administration. A good urine output of more than 150 ml per hour in the 6 hours after radiological procedure has been associated with reduced rates of acute kidney injury in few studies. To achieve the above high rates of urine output, you have to give fluids 1 to 1.5 ml per kg per hours. They have to be given for 3 to hours before and 6 to 12 hours after contrast media exposure. This is in high risk groups. Guidelines recommend not using oral fluids alone in patients at increased risk of contrast-induced acute kidney injury. Contrast-induced injury can also be prevented by using in conjunction oral N-acetylcysteine 600 mg BD for 3 days starting 1 day before the intervention, for a total of 3 days starting 1 day before the intervention, together with IV isotonic crystalloids in patients at increased risk of contrast-induced acute kidney injury. Important thing to note is that FDA label is available for N-acetylcysteine as a preventive drug for acute kidney injury. Guidelines suggest not using prophylactic intermittent hemodialysis or hemofiltration for contrast media removal in patients at increased risk for CI-AKI. So non-pharmacological prevention strategies of contrast-induced acute kidney injury: use the lowest dose possible, perform CT when possible without contrast media, dosing per kilogram, adapt injection duration to scan duration. So contrast should not be running when there is no scan running. Use as a saline chaser. So saline should be pushed in to flush the contrast from the IV channels. Angiographic strategies to lessen the dose. So, what is the timing of renal replacement therapy in acute kidney injury? So, this is a controversial topic. As per the current level of evidence, there is no unanimous decision regarding the timing of renal replacement therapy. So, in emergency, you have to do it. Initiate RRT emergently when life-threatening changes in fluid, electrolyte, and acid balances exist. Consider the broader clinical context and trends of laboratory tests rather than single blood urea nitrogen and creatinine thresholds alone when making the decision to start RRT. Discontinue RRT when it is no longer required, either because intrinsic kidney function has recovered to the point that it is adequate to meet the patient's need, or because RRT is no longer consistent with goals of care. Life-threatening indications of RRT. So hyperkalemia, say potassium more than 7, or ECG changes are appearing, so arrhythmias. So hyperkalemia is a emergency indication. Metabolic acidosis worsening, pulmonary edema, fluid overload which is refractory to say medical management, uremic complications, pericarditis, bleeding, encephalopathy. So what are the relative indications in toxicology? Say drug intoxications, various drugs, sodium valproate, lithium salicylates, theophylline, alcohols. These can be removed by hemodialysis. Rhabdomyolysis, so you can treat with hemodialysis electively after stabilizing the patient. Severe hypernatremia, hyperthermia for cooling the patients. Sepsis, this is a bit controversial. It is a relative indication because sepsis has underlying various cytokines and proteins responsible which can be cleared by hemodialysis. Diuretics should not be used to enhance kidney function recovery or to reduce the duration or frequency of RRT. And we have slow level daily dialysis, slow level low efficiency daily dialysis. Basically, there are two mechanisms underlying all the modalities, diffusion and convection. So in diffusion, small molecules such as urea diffuse fast and are therefore used as markers of efficacy, while larger molecules like beta-2 microglobulins, albumin, and protein-bound drugs diffuse slowly. Convection, drag of solvent moves the solute across the semi-permeable membrane along the hydrostatic pressure gradient. This is also called ultrafiltration, used for clearance of middle and large molecules. So basically, if I have to draw the diagram, in the what is happening in the intermittent hemodialysis, this is the blood flowing in the upper tubule. The lesser tubule, we make the dialysate flow. Both are separated by a semi-permeable membrane. So blood is flowing this way, the dialysate is flowing this way. This is counter current mechanism. So diffusion is when the molecules move from higher concentration to lower concentration across the semi-permeable membrane. And ultrafiltration is when the drag of the solvent pushes the molecules. So ultrafiltration, or we can say that convection, what it happens with the hydrostatic pressure. If the pressure in the upper chamber is more, it will push the bigger molecules also into this chamber. So dialysate, this is what we are putting it in here, making it flow in a countercurrent mechanism and taking it out. So various molecules are removed from the blood in the upper chamber across the semi-permeable membrane. If the uh, uh, purification process is occurring only by the process of diffusion, it is called dialysis, because the dialysate flow is there, dialysate inflow, dialysate outflow. If the process of purification is occurring because of the process of convection, it is called ultrafiltration. Then we call it ultrafiltrate, that what comes out. So in ultrafiltration, we have to have some replacement fluid in the outflow tract. But in only the process called dialysis, where the purification is by diffusion, you need not have a replacement fluid. The dialysate, a mixture of electrolytes along with buffer bicarbonate, is run in the countercurrent mechanism through the filter, and diffusion occurs through the membrane, removing urea and other toxin along with the fluid. The duration of RRT is frequently short, 3 to 4 hours, and blood flow is say 100 to 200 ml per minute, and dialysate flow is 300 to 500 ml per minute. Since the therapy is administered rapidly, it often causes fall in BP on initiation as well as shift in serum osmolality. The most common complication, hemodynamic instability, can worsen cerebral edema, requiring adjustment of blood and dialysate flows. CRRT, the therapy is initiated and maintained on a continuous basis for more than 24 hours, as opposite to 3 to 4 hours in IHD. Unlike, it is associated with better hemodynamics because it's slow process or fluid removal and minimal fluctuation in serum osmolality, less chances of cerebral edema. So we have various modalities of continuous renal replacement therapies. These modalities are divided on the basis of vascular access, whether we are having venous to venous, arteriovenous. So hemofiltration is where only filtration by convection, and dialysis we label it when it is by diffusion. So it can be slow continuous ultrafiltration. So this is called SCUF. So this process, this is a very slow process. It is done in CHF patients, congestive heart failure patients. Then we have continuous veno-venous hemofiltration, continuous arteriovenous hemofiltration, continuous veno-venous hemodialysis, continuous arteriovenous hemodialysis, continuous veno-venous hemodialysis plus filtration, continuous arteriovenous hemodialysis plus filtration. So this is the terminology. So whenever you are taking the blood out, so you have to have some anticoagulation. The need for anticoagulation has to be weighed against bleeding potential. Frequently, patients on RRT have associated coagulopathies. Uremia itself leads to a coagulopathy. So the decision for anticoagulation is often individualized. Kidney disease improving global outcome guidelines recommend regional anticoagulation for CRRT. Use of citrate is preferred for achieving regional anticoagulation. Liver dysfunction is a relative contraindication, as in them it leads to citrate toxicity resulting in low ionized calcium levels. So whenever you are using citrate, you have to monitor calcium. In fact, you have to monitor all the electrolytes. Writing the prescription is very important. Whenever you are taking for hemodialysis, what you target, it has to be there in the prescription. The prescription for CRRT should include the type of therapy, as already discussed, blood flow rates, dialysate flow rates, and type, what you want to be there in the dialysate. In fact, you can add and subtract electrolytes in the dialysate. So anticoagulation type, whether you're using heparins or you are using citrate, and what is the net you want. So the prescription is very important. The monitoring requires frequent measurements of electrolytes, which may be scheduled 6 hourly or 8 hourly. RRT patients, this is very important for any physician, any intensivist dealing with the critical patients. This is always very bothersome, deciding antibiotics and other drugs. Enhanced, let us try to solve this question. Enhanced elimination of drugs during renal replacement therapy is influenced by many factors. All of the following factors enhance elimination except: number 1, low protein binding; number 2, low molecular weight; number 3, high lipid solubility; number 4, duration and mode of RRT. So the answer for this question would be high lipid solubility. Why it is so? Because drugs which are having low protein binding, they are easily available, So they will be easily removed by RRT. Low molecular weight, easily diffused through the semi-permeable membrane, so easily removed by RRT. High lipid solubility drugs will not be removed by RRT because they are already bound to the lipids, so they will not leave the uh, blood through the semi-permeable membrane. Duration, more is the duration, more removal is possible, and more definitely will, if you are using filtration, it is effective for removing bigger molecules, and if you are using diffusion or dialysis for smaller toxins, smaller molecules. So antimicrobials, this is a golden rule or the pharmacodynamics which decide what should you do. If we have to solve before this slide, let us try to answer this question. A 30-year-old female underwent emergency laparotomy for perforation peritonitis, lands in your ICU with acute kidney injury and septic shock. On day 2 of ICU stay, her renal functions further worsen with serum creatinine say 3.4 mg/%, serum urea 102 millimoles per deciliter, requiring a renal replacement therapy, intermittent hemodialysis. Her current antibiotics were piperacin tazobactam 4.5 gram IV 6 hourly, and amikacin was going on 1 gram 24 hourly. Now with the new kidney functions, how will you optimize the antimicrobial dose? So this is a very common clinical scenario. It can be because of sepsis, it can be because of post-surgery. So how do you do it? You were having two antibiotics going broadly, piperacin tazobactam, beta-lactams are going on, then you have aminoglycoside going on. What you will do? Number one choice, you reduce the dose and frequency of both the above antibiotics. Number two, reduce the dose frequency of amikacin and continue the same dose of piperacin tazobactam. Number three, continue the same dose of amikacin but prescribe it every 48 to 72 hours and reduce dose of piperacin tazobactam with same frequency. Give the same dose and frequency of both the antibiotics. So the answer is third. Why is it so? Because it is because of the pharmacodynamics of the various drugs. Some drugs are time dependent drugs, some drugs are concentration. So this amikacin is a concentration dependent drug. So it requires bolus administration, that it will require a larger concentration, which is say 10 times of MIC value. And the beta lactams, these are the drugs which are time dependent. So these piperacin tazobactam, ceftriaxone, these are dependent upon a parameter which is called area under curve, AUC. So here the infusions are important. So you can decrease the dose, but you can't decrease the frequency. In amikacin, you can decrease the frequency but don't decrease the dose. Thank you.